COVID surgery and the implications in head and neck perspective. Thank you.
Right, can you see that, Jay?
Yeah.
Just making sure, perfect. So first of all, Jay, I'd just like to reiterate the thanks and for organising such an amazing conference on Zoom. And for people like me who are technologically challenged, it's been it's been an enlightening experience. But thank you for all your help and for your your enthusiasm for getting this working. So I'm going to talk about the COVID surgical outcome with a head and neck perspective. And as we are all aware that there are many centres worldwide have been collecting data about surgical outcome in the COVID pandemic, and publications are now beginning to be available. However, it's going to take, in reality, many years for the impact of the pandemic to be realised. No, that's not working. Within the UK, Birmingham has been leading the central data collection, and they've done that under the auspices of COVID surg. And it's been led by a colorectal surgeon called Anil Bangu, who's very kindly provided me with slides and information for this morning's talk. And they very quickly recognised that the response to COVID across the world required a rapid redesign of the clinical services to deprioritise the non-urgent surgical care. They recognised also that the hospitals and health systems needed to continue to manage cancer patients, because we all know that delay in cancer care will lead to a poorer outcome. However, we have to maintain treatment for cancer, but we have to acknowledge that it would put them at higher risk of complications due to COVID. And so there was an emergent need for a better understanding of the impact of COVID-19 on the care of cancer patients requiring surgery. So this group, under the auspices of the National Institute for Health and Research Units of Global Surgery, responded by collecting and connecting a network of units over 2,000 centres in 110 countries, more than 12,500 email addresses and many Twitter followers. The first paper they published in May 2020 in the British Journal of Surgery was looking at the predicted cancellations for the COVID pandemic, and it was using global predictive modelling to inform a surgical recovery plan. So essentially in the UK, we could go to the NHS and say, this is what has been predicted, this is the extra resources we're going to need. And to do that, they used a Bayesian regression model to estimate the 12-week cancellation rate for 190 countries at the worst point of the pandemic. And the headline results are that over 28.4 million operations were going to be cancelled during the height of the pandemic. Of those, over 2 million of them were going to be patients that required cancer surgery. So nearly 3/4 of all operations were predicted to be cancelled, and not surprisingly, the highest cancellation rates were those in benign disease and orthopaedics. And I'm sorry, I'm not sure if you can see that because it's behind my screen, but essentially within the UK, what they predicted was that when the NHS gets back to its full capacity, if we were able to increase capacity by 20%, it was still going to take 11 months to get rid of the backlog. Now, I'm sure many hospitals have been more effective, more efficient at getting up and running, but where I currently work down the South Coast, we're not back at normal elective capacity yet. So this 11-month delay is just being put on the back burner. So interestingly, 40% of head and neck cancer surgery was predicted to be cancelled. And not looking specifically at head and neck cancer, but at all cancer surgery, there was predicted to be a huge difference in the cancer surgery cancellation rate between 30% cancellation rate in the high income countries compared with 70% cancer surgery cancellation in the low income countries. So then they went on to look about death rates associated with patients undergoing surgery during the COVID pandemic. And in order to capture the data for this, they looked at the 30-day mortality rate of patients who had come in under either for elective surgery or emergency surgery, and they captured data to see whether they had COVID for their cancer care. Patients who were excluded were patients having palliative care procedures or patients just planned to have chemoradiotherapy with no fixed plan of surgery. We were all asked that for those of us that contributed, and I'm sure many of you listening to the conference today will have contributed data to this, we were asked to fill in information on REDCap, and it includes a number of parameters outlining the type of cancer, the type of surgery that was predicted, whether it was delayed, whether we altered our predicted management due to the COVID. And all of these patients had to pass through a certified MDT. The first of this data set for the mortality is now being published in the Lancet, and that was published in May. And in fact, the next papers that are due to be published are due to be published in the next week or two. So for this paper, it was an international multi-center cohort study, and it was looking at the perioperative COVID infection. So within 7 days of surgery or 30 days after surgery. And the patient was included as COVID positive if they had either laboratory, so using RT-PCR, radiological, so CT chest, or clinical diagnosis of SARS. And I know the clinical diagnosis of SARS sounds a little bit vague, but basically they were saying that in some countries, there was just no access to other ways of confirming whether patients had COVID or not. So if a senior clinician said that the patient was behaving in a way that was consistent with COVID, then they were included in the analysis. And the outcomes were 30-day mortality, and the secondary outcomes were the pulmonary complications. And they broke those into pneumonia, the acute respiratory distress syndrome, or unexpected post-operative ventilation. So some of the data that came out of the Lancet paper. So they identified 1,128 patients, and that's what we're going to look at during this next couple of slides. And the mortality for patients that underwent surgery during that period was 23.8%. If we break that into two data sets looking at elective surgery and emergency surgery, the majority of patients being operated on who had COVID either pre or post-operatively were emergency surgery patients, and that was associated with a higher mortality of 25.6%. So if it was elective surgery, if it was booked surgery, it was less at nearly 19%. So when were these patients diagnosed? From these 1,128 patients, 25% of them were diagnosed preoperatively in that 7-day window. The majority, 71%, were diagnosed postoperatively. And the mortality between the two was only subtly different. So 21% if you were diagnosed preoperatively, or almost 26% if you were diagnosed postoperatively. If we look at whether a patient was categorized as major surgery or minor surgery, and in order to categorize them, they actually used the BUPA system, and BUPA is a private healthcare system in the UK, to categorize whether BUPA would have categorized it as a minor or major surgery. It was more significant if you had major surgery, then you were more likely to die if you developed COVID than if you had minor surgery, where the mortality dropped down to 16%. And the 30-day pulmonary complication rate, it was about a 50-50 split about how people presented. If you had no pulmonary complications, you only had an 8.7% chance of death. But if you did have pulmonary complications as a result of the COVID, it leapt up to almost 40% of patients dying. If we look at those pulmonary complications in more detail, so we know that 52% of those patients, of all of these patients that had a pulmonary complication. If the patient developed pneumonia, they had an almost 40% chance of dying. ARDS gave you a 63% chance of death, and unexpected ventilation was 41%. So the one not to get if you had COVID was ARDS, because that put you at a 60% chance of dying. Some of the data has been broken down to head and neck, but head and neck unfortunately only contributed to a small data set of those patients that actually got COVID during the pre and post-operative period. But if we can look here, 32 patients that were entered did not die. 8 patients did die during that window of collection. And the majority of patients who had complications, they did have lung complications when they'd undergone head and neck surgery. If we look at this a different way and we look at odds ratio, so we use odds ratio to look at the risk of something happening, and by splitting up the data like this, you can basically say that patients over 70 years who undergo surgery had a 2.5 times risk, or greater than 2.5 times risk, of dying as a result of that surgery if they got a COVID infection. And using that odds ratio to look at different parameters, we can say that if a patient was male, it had a significant increase of death with COVID if they got infected in the post-operative period. The ASA grade, which is obviously the American Society of Anesthesiology physical status classification, those patients that were further down the spectrum of being a poorer anesthetic candidate had a significantly increased chance of dying if they developed COVID. Cancer surgery was linked with an increased risk of death, but trauma surgery wasn't. Emergency surgery, as we've already discussed, did have an increased risk associated with it, as did major surgery. And it didn't make any difference whether the patient developed their COVID diagnosis pre or post-operatively. So the take-home messages from the study, from the COVID surge, is that the threshold for surgery should be raised during a COVID pandemic, because we know patients who develop COVID during this period are more likely to die than those that don't. Men over 70 undergoing emergency or elective major surgery are at particular risk. Overall, our patients are at greater risk in the COVID era, and the factors that predict a better outcome for developing COVID are younger patients with minor procedures, low risk of anaesthetic, and female patients with benign disease. So what are we doing in Poole Hospital? And just to show you where Poole is, so Poole's all the way down here, whereas Jay is all the way up here. So down in Poole, we are isolating patients for 3 of all 14 days of isolation pre-head and neck surgery. So if a patient is elderly, so over 70, and they are male and they are having major surgery, we are isolating them and their family for 14 days. If it is considered to be a less risk operation, so they are younger, they are female, it's a shorter procedure, we're only asking them to self-isolate with their families for 3 days. We're then COVID testing them 72 hours prior to surgery. So finally, just talking about COVID, I think it's nothing short of a miracle that we got such good outcome data with this pandemic, because I'm sure all of us who were wearing the equipment to operate on found it difficult to communicate effectively and difficult to even to achieve the same level of visual acuity. So I think that there are many problems associated with COVID, not less the way that we've had to adapt to operate during these times. So I think that's the end of my presentation. If there are any questions, I'd be happy to take them.
That's a great presentation, Emma. It's spot on. I really like this. I got 1 or 2 questions. So when is the good time to operate? Is it going to, the pandemic is still on and we do get second waves. Are we okay to do elective surgeries?
So elective surgeries so I'm very much head and neck surgeon. We down in Poole, we haven't started doing very much elective ear surgery or rhinology. But for our elective surgery, the only patients I'm operating on are patients who have cancer. And I think that these patients do need diagnostic biopsies. We do need to work out the best form of management. And during the peak of the pandemic, we were trying to steer away from big surgery. We were certainly steering away from free flap reconstruction. But now we have become more relaxed about it. Whether that's right or not, I don't know. And also at the beginning of the pandemic, the oncologists were very much steering away from chemotherapy. So there probably is a cohort of patients that have come through that weren't offered big surgery, that actually probably weren't given chemotherapy in some centres either. And it'll be the outcome from those patient data that we'll see in years to come, which we may not have best served patients, but we were damned if we did and damned if we didn't. It was a difficult position to be in, I felt.
And they were asking, is there any increased mortality and morbidity in PAME population for surgical patients during COVID pandemic?
So that data hasn't been teased out of the COVID surge papers to date. It could be one of the ones that's in the pipeline, I suspect.
That's fantastic, Emma. Thank you very much. That's great. I appreciate your time and your technical time, Emma.
Thank you very much.